Hello everyone. My name is Heman and I'm a research associate at South Asia Research Institute for Minorities. Today we have very special guest with us for an interview. She is Dr. Sylvia. Dr. Sylvia is a public health doctor and a researcher with a specific focus on social determinants of health, especially caste and nutrition, and a regulation of the private health sector. She writes for mainstream media, peer-reviewed journals, and conducts health education sessions for marginalized community and health workers. So without any further ado, let's dive into the questions. My first question is the COVID pandemic highlighted an often glossed over issue which is instantly ignored condition of the health and sanitation worker who are bound to do jobs in harmful environment and unhealthy surroundings like disposing of biomedical waste without adequate protective equipment. What measures can be adopted to prevent these workers from detrimental condition of workplace?
Yeah, thank you, Heman. I think that's an important question for us to start with. Basically, if you look at the healthcare system, and if you look at whether it's inclusive and whether it is available to everyone equally, one can see that both within the healthcare system and by the system, there is some amount of discrimination. Certain communities have been traditionally not able to access the healthcare system the way the other communities have been able to. And within the system itself, first of all, if you look at medical education, there is there is not enough representation in terms of the population. It's dominated by people from elite urban middle class, mainly English speaking city dwelling, and also dominant caste groups, and therefore they tend to also create a health system which is very catering only to a very narrow class and caste group. And while we have on one end of the spectrum the doctors who are often treated as gods, and who even any kind of regulation is seen as some kind of insult for them. Basically, a doctor cannot do wrong. You cannot question a doctor. That's the kind of mentality that is there, both among the healthcare system and also by the people accessing these services. But on the other end of the spectrum, if you look at the people who are mostly what we call the invisibilized frontline workers. I think their role became very evident during the COVID pandemic, and also the kind of violations that they faced, whether it's labor law violations, the kind of harassment they face, the kind of discrimination, the kind of verbal abuse, and also exposure to a lot of occupational hazards. So people working within the healthcare system have specific occupational hazards, and especially these frontline workers, they handle a lot of waste, they handle a lot of chemicals, they handle dead bodies, they handle very sick patients. In terms of COVID also, they were exposed, they were vulnerable to exposure to a lot of infections, but they did not get a preference in terms of, say, the protective kits or vaccinations, or even, getting reimbursed for working extra hours. And most of these people are from the Dalit communities. So it's people who are cleaning, who are handling the bodies, who are cleaning the toilets, who are handling the sanitation, who are disposing the garbage, who are working in mortuaries, who are working in burial grounds. Very often they have very little rights, they have very little dignity, and a majority of them are from the Dalit community. So this is a very stark example of how the system itself is casteist. Why some lives or some workers are less valuable than other people. And the obvious difference is, class and caste, and to some extent gender also.
Thank you for highlighting this issue. So I was watching your other interviews where you mentioned that the healthcare system is quite doctor centric in India. Can you please elaborate this little bit?
Yeah, so like I said, in India, the doctors are treated like gods, and especially if you do a breakup in terms of caste and class, most of them would be men, and they'd be like from dominant caste groups. They're mostly from elite or rich backgrounds, And there is a kind of a false belief that health means these doctors. But actually, if you look at healthcare from a more sociological perspective, what we call the social determinants of health are very important. So we say that the a community that has good access to water, to sanitation, to education, to basic, dignified livelihoods, to nutrition. That community itself is more likely to have better healthcare indicators. But in India, there is very much a focus on this very curative model of healthcare, and most of these, curative facilities are like tertiary hospitals located in the urban areas. Again, this became very visible in the pandemic, because even for basic things, basic testing, basic treatment, people from the villages and in remote areas have to travel long distances. And India had quite a regressive kind of a lockdown during the pandemic. So even the public transport, public toilets, all of those were shut down. People lost their livelihoods, and that contributed hugely to the kind of negative outcomes that happened during the pandemic. And even within the healthcare system, the role of the other people, like for example the nurses work tirelessly, and in fact they in many cases, they in many health facilities, they run the hospital. They're there in the ICUs, they do the deliveries, they're there at nights, whereas the doctors may only be available on a call. And you have the pharmacists, you have the lab technicians, you have the other administrative people, and of course, like I said, the other frontline workers. Very often they are not seen as equal players or as important people within the healthcare system, and that affects the way healthcare is delivered. First of all, the regulatory mechanisms. Anytime there is a attempt to regulate the doctors for overpricing or for bringing in some kind of a standardized or a rational evidence based treatment, there is a lot of opposition. Basically, they say that we are so big that we are above regulation, and that is hugely problematic, because doctors at the end of the day actually dealing with human lives. They're dealing with life and death. In fact, they need to be much more regulated than other professionals. And the other thing is, because of this attitude, I think there is a tendency to not learn from traditional systems of medicine, which there is a vast knowledge among people, among communities. People trust the traditional practitioners. So I think there has to be a sense of learning, and more humility as far as the medical professionals are concerned. And till now, the kind of medical education, especially allopathy, is very westernized. So in fact, doctors are more likely to know what is happening in, say, the US or the UK, rather than actually Indian diseases, what we say, like say tuberculosis or malnutrition. There's very poor understanding, and very little skill actually in handling some of these diseases. Even the research again comes from a very Western model, very Western understanding, and I think that is problematic in many ways.
I totally agree with you. You have incredible work and interviews. From that, I found out that you said that doctor at the top of system is always a Brahman male doctor. That made me curious about how individuals from dominate caste control access to health information and treatment in India. What sort of health treatment is provided to lower caste people by an upper caste doctors?
See, like I said, within the medical education, there is very little representation of people from the marginalized communities. And even the few people who come, they do face a lot of harassment, a lot of discrimination, a lot of verbal abuse. And there is a case of Dr. Payal Tadvi, uh, who was a Muslim, tribal Beal doctor, who actually took her life because of the extreme kind of harassment that she faced. And the few things that actually important from that death is, one is she, her mother, and her husband actually tried to access different systems for justice, because she was facing so much of harassment. She approached the different officials and different committees, and most of them did not give her the kind of support that was very much required. The other thing is that even within other doctors, the way they responded to that death is by saying, all of us as doctors face some kind of harassment and discrimination. So why are you making this about caste? Why are you saying she's faced caste-based harassment? So I think it's important to draw that line between isolated incidents of harassment or bullying or by one individual. So which all of us, like I'm a doctor, and all of us have faced that. Someone doesn't like you, they're mean to you, they'll give you extra work or they'll talk down to you, and you feel bad, and you feel hurt, you feel humiliated. That's still isolated events or by individuals. But what Dr. Payal Tadvi clearly faced was a systemic harassment, was a systemic bullying and systemic discrimination, where at every step she faced, the people treating her badly, people treating her, in a humiliating way, and also exclusion. So sometimes we talk about overt casteism, overt discrimination. Like we might say, that person spoke to me in this way, which was humiliating. But there is also covert, where you get excluded, you're not given information about conferences, you're not allowed to do surgeries, which was what was happening in a case. A surgeon, she's a gynecologist, training to be a gynecologist, she's not being given opportunities to operate. So that is, process of exclusion, which is a covert form of discrimination, which is happening to a lot of people. And in fact, if you look at social media, you can see how rampant the kind of bullying based on caste and based on religion is in the Indian context, and there is absolutely no regulation. People get away with impunity. In fact, they're goaded and cheered by other doctors. Their own juniors and peers learn this kind of behavior, and if this is happening in public on social media, you can only dread to imagine what is happening in the confines of a hospital where there is actual power, inequality. And the problem that that we see is that there is no acknowledgement of this within the healthcare system. People are always trying to pretend that it's something else. They say, oh, it's normal stress, or they always try to rationalize it, they try to justify it. And in fact, a lot of these doctors who go abroad, they actually say they face discrimination. They say, we are Indians or dark skinned people, we need affirmative action. But these same people, in the Indian context, they talk so badly about reservation. And I think it's important that to understand that reservation based on caste is not based on income. It's not that if they talk about creamy layer, they say, this person is Dalit, he has a card, he has an iPhone, he has a his parents are well educated, they have a big house. But it's also about representation. The more we have representation from communities within decision making, whether it comes to healthcare or whether it comes to social determinants, the more likely we are to improve these systems.
Thank you for
And
putting on
sorry, one more point I want to add is that in India, there is also this growing communalism. Again, to use the pandemic as a framework, the crucial time was lost. Instead of preparing for the pandemic, the media, the government, a lot of bureaucrats, were talking about Tablighi Jamaat. They were targeting the Muslim community. They were calling for economic boycotts. They were calling for social boycotts. In fact, people were being discriminated within the healthcare system just because of their religious identity. In fact, there was a microbiology textbook which was put out, which said that talked about Tablighi Jamaat as the focal point for the epidemic outbreak. So it's a combination of prejudices and also poor science. Like if doctors understood basic epidemiology, or they understood basic ways of how a disease is transmitted, they would not talk such nonsense. They would not, blame a community or target a community. So even the way, medical education is, it's very prejudiced. It's still, based on the personal prejudices of the faculty, whether it's caste prejudices or religious or gender prejudices, rather than actual up-to-date evidence-based scientific information.
Thank you for bringing out the Priya's case. It really makes the sense. If you are the expert of nutrition concerning nutrition, there are also controversial religion and caste-based influence in policies that provide something like daily midday meals. How does this influence occur and what's supposed to be a fair policy?
It's in terms of nutrition, it's a very important social determinant of health, and I think you don't need an expert to understand that if you have poor nutrition, then you're unlikely to be healthy. It doesn't matter how many medicines that you take, and along with that, of course, a lot of other factors. But in terms of nutrition, there is two ends of the spectrum. On the one hand, you have the science, the science of nutrition and what it says. On the other hand, you have the traditional practices of communities, like, say, the majority of, say, Indians who are Dalit, Adivasi, and OBC communities. A lot of them have a basic understanding of nutrition, which is actually quite closely aligned with what the science says. So basically, the science says that you should have diversity, you should have local foods. It should be foods that you're able to digest. It should be foods that you're able to absorb. Taste is very important. The cultural context is very important. So, for example, if you take someone from South India and if you give them like rotis every day, it doesn't matter how nutritious it is. They're not going to be happy eating it, and they're going to consume lesser quantity. So the cultural context is very important. And we have different food groups. So it's important that diversity comes from different food groups. So you have cereals and millets, you have pulses and legumes, you have fruits and vegetables, you have milk and dairy and meats, poultry, fish. You also have fats and oils. And diversity means, having the adequate quantities from each of these food groups. But in India, we have the people in power who are mainly from a dominant caste group, who identify as vegetarian, who want to push the idea of vegetarianism as a, that's the face of India. Like, you'll hear a lot of people who are abroad or who talk about India and say India is a vegetarian country, but that's not true, because it's only about 20% of Indians who have actually self-identified as vegetarian. And if you look at the composition of milk and dairy, then even those who consume milk and dairy cannot technically be classified as vegetarian, because it's an animal source food. It comes from an animal. And so the people who identify as vegetarians, they're also, because of their caste location and class location, more likely to have diversity. Like, they're more likely to have milk products, ghee, butter, paneer, nuts, fruits, vegetables, pulses, and legumes. And therefore, even with that diet, without meat or poultry or fish, they can have, over time, they can show an increase in heights in terms of different, subsequent generations, which is a good measure of the nutrition of a community. But because they are in decision-making position, they tend to push cheap vegetarianism on the rest of the people. So by cheap vegetarianism, I mean only focusing on cereals and sometimes millets. So their idea of diversity is, if instead of having rice every day, you should have some millets every day. But that's not diversity, because both cereals and millets belong to the same food group. So there is an erasure of all the other foods that people have been traditionally eating, and which nutritional science says that you have to consume these foods. So, for example, across the country, we have cattle slaughter bans. We have laws coming in saying that you should not slaughter cattle. And these laws are brought in without any thought given to who is consuming beef, who are the people who are trading in cattle, how are they affected? How is their livelihood affected? What is, the income that is lost? Is there any alternative in terms of nutrition for them? None of that is factored in. And beef, if you take beef, it is a very nutrient dense food. It is, even if it's consumed in small quantities, even or especially organ meats, they provide a lot of the protein, vitamins, minerals, fats that is required for the body. So nutritionally, it's a very important food that people, have been consuming and should consume. But because of unscientific reasons, these cattle slaughter bans have been brought in, and now, like, we did a study on that, and I can share that link. Right from the farmers to people who are working at the leather industry, people who are working, with the butchers, the slaughterhouses, the people who are working with the byproducts of the cattle, all of them have been affected very badly, especially post-COVID. Many of them have lost their livelihood and they're in very dire circumstances. They're not able to support their families. They have no support from the government, and they are now being criminalized and targeted. So if you look at the kind of news that comes out, they'll say this person was caught with suspicion of, illegally smuggling beef. So what is a normal trade, normal income generating activity? Overnight, it gets converted into a criminal activity, and people, get attacked. I'm sure you must have heard of the lynch mobs. Then you have these self-appointed Gaurakshaks who actually, just antisocial elements who just attack people, make videos of these, and mm, it's a very morbid kind of behavior that has happened around these cattle slaughter bans. Apart from that, we have the eggs, which again, if you look at it from a nutritional point of view and traditionally consumed by a lot of households, it's a cheap source of food. It's a very rich and again a very nutrient dense food. It's something what we call a complete food. It has most of the nutrients that people require, but that again is criminalized, and in fact, in many states, they refuse to give eggs in the midday meals, and citing religious reasons. They say our religious sentiments are going to get affected. So then religion, ideology, caste becomes the basis of deciding the midday meals rather than science. And that apart, there has also been targeting of different other kinds of meats, especially in BJP ruled states, they say we want to shut down meat shops around religious festivals. Meat shops should not be allowed to operate in certain areas in certain times of the year. Then they say boycott halal meat and you should have only jatka meat. So there is a constant processing of targeting and criminalizing not just meat but also meat eaters, and this is a huge problem in the Indian context. And along with that, you have an influx of this very ideologically driven organizations. Like, for example, you have the Akshaya Patra, which is, it's a concern of the International Society for Krishna Consciousness. And they believe that food should be sattvic. They've been given contracts for the midday meals across the country in different schools. Uh, Schools which are actually accessed by meat eating, egg eating children who are used to eating onion and garlic. And Akshay Patra refuses to use all of these in the food, saying it is tamasic or it is rajasic. Again, this has no scientific basis. It is a very ideologically driven propaganda, driven agenda, but they've been given the contracts in the midday meals. Children are unhappy with the food being given in the midday meals, but these organizations have a lot of power and they're able to lobby, at a high level with the ministers, with the chief secretaries, principal secretaries, governors, and they're able to get these contracts in spite of several complaints against them.
Thank you for highlighting this. I think everybody needs to hear this, especially. Would you like to tell how Dalit have been compromised, especially when it comes to health treatments? What the future holds for them in India? Is there any progress? Do you see?
Yeah, I think the first step to addressing caste and now also communalism. And based on that, the adverse, there are numerous adverse outcomes. The first step is to acknowledge it, and I think there is a lot of denial, even whether it's civil society or whether it's governments or even human rights organizations. There is a hesitancy to talk about caste and communalism, and unless we talk about it, it will be difficult to take steps to address it. So if once we address it, I think there are multiple levels of intervention. So I think it's very important to have representation of people from marginalized communities in all decision-making process, whether it's healthcare or the social determinants of health. And therefore, the reservation has to be implemented in spirit and in practice. And it's not only about tokenism, it's not only about numbers, like saying, it's not a tick box. Okay, I've got one person who's Dalit, or I got one person who's Muslim, or one person who's, tribal or Adivasi. It's also about making these spaces safe, making these spaces such that people don't feel threatened. So, a lot of people uh, representing, some oppressed community, but they go very silent, they go very quiet, because they fear for their jobs, they fear for their lives, they fear for their families, they fear for their social status. All of that is under attack. So the process of inclusion has to be, what you say, it should be genuine. There should be genuine political will to bring in representation and decision making. And once that comes in, I think people should be treated as equal players. You can't have these so-called experts who have proved that they're not actually experts. They're people with either a caste or a corporate agenda. They if you want someone to make decisions, they should be people who use evidence, who have a scientific way of thinking, who have an understanding of the community, who understand why representation is important. But most often the people who make decisions don't have all these skills. So unless that is addressed, the day-to-day reality of people is going to be very problematic. The question you asked is, what is the experience of people accessing these services? Mostly it is discriminatory. There is a very top-down kind of attitude. The people who are poor are also treated as stupid. It's like you're sick, but you're also stupid. So I'll treat you like you don't have brains. I'll treat you like you don't have agency. I'll humiliate you. And especially when people are accessing private facilities, money makes a big difference. So I think it's very important also to try to bring, if they invest the taxpayers' money in more public facilities, which are more universal and more accessible to all people. The healthcare shouldn't become an elitist space that you can only afford to access healthcare if you have money. And I think that tendency is very much there. And I think, again, that comes from who's making the decisions. We have a lot of closed door decision making. We don't know who's making decisions about our healthcare. We have like global companies, we have pharma companies, we have large corporates, we have tax companies which are sitting and making decisions. Again, very non-transparent, complete lack of accountability. So, for example, we had experts deciding about the COVID pandemic, but we're not holding anyone accountable to say, what were the decisions that these experts made? Were they right decisions? Were they qualified to make those decisions? Did they have the skills? Did they have the knowledge or understanding? And if not, then are they going to be held accountable? None of these things happen. So people get away with some of these very problematic decisions. And I think that has to change. I think people who make decisions for healthcare and social determinants have to be held accountable for bad outcomes.
Okay. In India, secularism entitles taking a neutral position towards all religions, regrettably, which equidistance never materialized. Do you agree with this statement?
Yeah, I think that's becoming very visible now, that if you're if you are a Hindu in India, then you have certain rights, and if you are a non-Hindu, then you you can't even expect basic rights. And we are seeing that in in different forms. For example, we have the issue around the hijab. Thousands of girls have been denied access to education, and it's the hijab is a marker of the religious identity. There's so much of targeting, and in fact that has become a way of even boys bullying Muslim girls and thinking that it's okay for students to discriminate and abuse their classmates only for the reason that they're wearing a hijab, and people think that's okay. But we have so many markers, Hindu markers within all spaces, in the all public spaces. You have pujas being conducted in government facilities, even in high courts and police stations. Walk into any police station, you'll see a display of Hindu gods, people doing pujas, making making people wait while pujas are being conducted. They call pujaris into hospitals to do pujas. Schools, lighting of the lamp, and having a Hindu ceremony or Hindu symbols are so normalized. But the someone from the other religion, even small actions are treated as crimes. So definitely I would say that there is an othering of people who are non-Hindus. And in fact, recently the anti-conversion bill was brought in Karnataka. So basically, you can convert uh, from any other religion to Hinduism. That is not seen as a forced conversion. That is seen as normal, and that is seen as acceptable. It's called garva apasi. It doesn't matter what are the mechanisms that were used to bring people back into Hinduism. But at the same time, if someone converts from Hinduism to another religion, even an adult, a consenting adult with agency, they are, then almost become as criminals. They have to face the law, they have to, face potential imprisonment. So there is a lot of targeting of minority communities, especially people from the poorer, even from these religions, it's the poorer people who get targeted.
We can see the Dalit, anti-Dalit sentiments in India. What strategies can have to resolve this issue, and what methods have been adopted in past?
About the past, I mean, I can only comment about the reservation, which again is not being implemented in the true spirit. It has to be implemented. So people from students from Dalit communities actually are entitled to get some scholarships, but many of them are not actually getting the scholarships on time, which is definitely going to affect the access to education. The policies around education also changing. We have the national education policy, which again is seen as a barrier to some of the students from traditionally oppressed communities actually accessing higher education. We the way, like for example, what I said, the people who are working as sanitation workers or cleaners within the hospitals or anywhere else, their incomes are so poor, and their access to social security schemes is so difficult that it's that this becomes an intergenerational occupation. The children sometimes are forced into the same occupations. So I think it's important that when it comes to caste and when it comes to marginalized communities, it is very important that at least the next generation, there is a political commitment to make sure that the next generation has better choice in terms of occupation, and better able to take up occupations which are different from what the family has been traditionally doing. And I think there's a lot of people going out from India, outside India. They're taking up senior positions, and they kind of propagate this whole caste and communal issues within India. Either they're sending back money or they're misrepresenting India. So I think it's important for universities outside India to also follow affirmative action in terms of getting students from communities in India which are traditionally oppressed and marginalized, and not only the dominant caste groups. There is a need for, internationally also, for caste to be acknowledged, for communalism to be acknowledged, and for affirmative action to also factor in these, when appointing faculty and when appointing, students for masters or PhD courses. And within India, we have laws, but most of these are not implemented. So I think, implementation of laws that protect marginalized communities have to be, uh, you know, they have to be done with proper intent. I think right now they're not being implemented properly. So there is a lot of impunity. So if there is a caste-based atrocity, the perpetrators know that they can get away because they either file counter cases on the victims themselves, they harass and bully the families, or they use their influence to, get away. They get bail, even though caste atrocity is a non-bailable offense. They do manage to get away, and therefore that gives a sense of impunity. Like what I was saying about social media, doctors are openly using casteist slurs. They're using communal discriminatory language because they know they can get away with it. So I think even social media, sometimes they don't have the means to identify caste-based discrimination. I think it's very important for the social media platforms to take cognizance of this and uh, you know bring in checks and balances and ways to control social media as a tool of harassment and bullying based on caste and religion and gender, of course.
Caste census holds importance in drafting policies, especially at the national level. In your opinion, to what extent can caste census help eradicate caste discrimination? What are the benefits of caste census, and what sort of challenges and obstacles are in the way of holding a caste census in India?
I'm not really an expert on this. Just to give a very general understanding, basically, I think caste census will help to understand the extent of the issue. So, for example, if you look at, say, different occupations, and you also see which caste groups are in those occupations, what are the incomes that those people are getting, and also in terms of their other indicators, the development indicators, their how much land they have, or how much the health indicators. um, it gives you a sense of where the resources should be uh, put in terms of decision making. It makes decision making much more evidence based and much more that there is much more equity in terms of decision making on where the taxpayers money goes to. And I think that is not happening. And I think that is a deliberate way of keeping people in the dark, that you don't know how many people are unemployed, and which caste group are those people belonging to, how many people are migrating from one state to another. Migrate people who migrate are more vulnerable. They have very precarious kind of lives. What caste groups are the people who are predominantly migrating from one state to another, and why is that state's social security schemes or policies not benefiting those people in such a way that they can find better lives for themselves and for their children within those own states. So I think a caste based census can give baseline understanding, and I think it's very important that it happens, and also that decisions are made based on the caste census.
We are observing World Day of Action for Women's Health on 26th of May. What sort of action or framework can be advised to ensure quality health service to all women, irrespective of their caste and religion? What message you would like to give for this day?
See, within the healthcare system, women are often treated as a miniature version of men. So if men get 20 grams of something, then the women will get 18 grams or 16 grams. Same with drugs, or with any other recommendation. There is very little research actually on women um, within the healthcare system. I think that's very important, that research should be um, focused on how women's bodies react, because women in terms of their body or the hormones, or chemical composition, the way they react to different drugs in different times of their reproductive cycle, it may vary, and it's very important. Like, for example, during COVID, the pandemic, nobody knew if pregnant women should get the vaccine or not, and it was just arbitrary decision making. They said, we don't know enough, so don't give it to pregnant women, which means the women are not able to access the vaccine. So there has to be very gender sensitive and gender specific research. And also, in terms of medical education, I think there is a need for doctors to be trained in, to be much more gender, caste, religion specific. And even within gender, I think there are intersections. Uh, a Muslim woman may not have the same experience as a Dalit woman, may not have the same experience as a Brahmin woman in accessing the healthcare system. So there is a need for the system to be sensitive even among women for differences, based on other identities. I'm also seeing that occupation makes a very big difference in how a woman experiences the healthcare system. Women, say, who are working as sex workers, or women who have, say, a stigmatizing disease like HIV, the way they are treated by the system is very bad, in such a way that they may be scared to access these services. There's so much of verbal abuse, there's this kind of sexual harassment that they face. So there's a need for the system to be much more sensitive and much more inclusive. And also, in terms of location, it's known that if a woman has to travel further and further away to access healthcare, she's likely to access it later and in much more serious condition. So it's very important that healthcare is available to women very close to where they live at timings that are convenient for them. So some women say that, we work the whole day and it's difficult for us to go during the day because we are daily wage laborers. Therefore, we are not able to go to the health system, because when we are free, the health system is shut. So they need to be stakeholders. There need to be consultation with women from different communities. It's not only some urban, English speaking woman who's sitting and representing the rest of the women. Even among women, there are different, identities, and there are different backgrounds. So there needs to be a representation of all of them. Senior citizens need a lot of much more attention, especially the women. Adolescent girls very often get left out. There's a lot of stigma around, say, adolescent girls, especially if they're unmarried, accessing, say, reproductive services, which means they go underground, they access care which may not necessarily be, the best quality, putting their lives at risk, putting their health at risk, making them susceptible to long-term complication and consequences. So definitely, the healthcare system needs to be much, much more inclusive when it comes to gender.
The most top topic in the town and globally is the monkeypox. Do you have to say anything about it? What kind of precautions we should do?
I mean, I wouldn't be the best person to talk about it, but all I would like to say is that in terms of any pandemic or any disaster, preparedness is very important for the healthcare system. We need to anticipate diseases, we need to anticipate natural disasters, and we need to have a system that is equipped to deal with it. We need to have good data, uh, reporting systems. But I think we have a long way to go in terms of that. Especially like if you look at COVID, we don't have a very good database on, what were the unique factors within the Indian context which affected how the virus mutated or how the virus responded in certain patients, how it interacted with, say, malnutrition, and in senior citizens, what were the drug interactions, what are the death rate, what are the long term, like what we call long COVID. And there is some discussion that possibly monkeypox is more likely to occur in patients who have had COVID or who have some kind of immunosuppression. So do we have the data? Do we have the research, that is reliable? I think that is a question that we need to ask. The lessons from the pandemic, I think we have to learn those lessons, and we have to prepare for, diseases, outbreaks like what we're seeing with the monkeypox. How similar is it to smallpox? What are the symptoms? How should people identify it? What are the protective mechanisms even before the disease occurs or in the early stages of the diseases? So all of this, we need much more evidence. We need much more research. And I think monkeypox is not the only outbreak that one can expect. We can expect, different, what we call the arboviral diseases, which normally don't occur with humans, but start occurring if there's a breakdown. Say if there's a breakdown between the human and nature interface, where people start entering more and more into wildlife areas, or there's unplanned constructions, or travel without proper precautions, unregulated kind of travel. So we need a team of people looking at all of this, and it's very difficult for, say, one individual, one doctor, one clinician, one public health person to have that kind of understanding of all the issues. We therefore need a group of people who are constantly thinking about this, who are constantly planning these things from a scientific basis. I think that is not our strong point right now.
That makes sense. How can SARIM collaborate with you and to promote minority rights in the region?
I think it's very important. I was seeing some of the interviews that you had done through SARIM. It gives a very a wide understanding, a very global kind of perspective on a lot of the issues. The solidarity is very important. The understanding is very important. The networking is very important. And I think, getting more people from different fields and different sectors to talk about it, to collate this information, and also to disseminate it. I think that would be a very important role that SARIM can play. We need objective, neutral bodies that we can go to. If, say, we want to get an understanding of something, we should be able to access it. I think SARIM can offer that space to people like us.
Last but not the least, Dr. Sylvia, I would like to thank you for your time and invite you to the conference. Would you want to join us in Pakistan for next gathering if the global pandemic situation stabilizes?
Definitely. I actually had a chance to visit Pakistan a few years back, but there was very little time for me to get my visa. So definitely, I think uh, it's good to know your neighbors. It's good to visit your neighbors and have good relationships with them. And I think there's lots in common that we have more than differences. So I think it's important that we all learn from each other. Definitely, I would love to.
Thank you very much for taking our time for interview. It was one of the best interview of mine with you, and I think we need more doctors and nutritionists like you in South Asia to bring out the positivity in the region. Thank you very much.
Thank you so much, Heman. Bye. All
Have
the
a good
best.
day.
You too.
Thank you.
Bye.